Good afternoon.
Hi, everybody. I hope everybody's doing well.
And holiday season is going well, and we're going to talk about tuberculosis today. And I think one of the big reasons we want to talk about this, we're seeing more and more cases, and you will see why, and we'll talk a little bit more about that.
Yeah, I think this is a good topic, not only about latent TB and active TB, but one of the big questions is who to isolate. And that's a question we get frequently. Does this patient need to be isolated? What should we do? How long should they be isolated? I think these are all frequent questions and good to discuss. So we'll go ahead and get started. And if anyone has questions, you can go ahead and type it in the chat, or just unmute yourself and ask us any questions that you have. So the objectives for today, we're going to talk a little bit about global tuberculosis, and then latent and active tuberculosis, and then treatment, and then who should be isolated.
I kind of like to start off sometimes with a question so we could think about a patient case as we are going through this process. So this is a patient we had, so a 25-year-old female with fevers, chills, weight loss, 2 to 3 months. And, she got lots of different types of antibiotic, thinking like, she has bacterial infection. And then finally, she wasn't getting better. So they did a CT of the chest, and there's a lot of lymph nodes and lung infiltrates. And so she was started again on another antibiotic course. So like when you hear this type of a story, I think it's really important to know what next questions do we ask. And, if you all have any ideas, or I'll just ask Dr. Horn, but what kind of next question will you ask Dr. Horn when you hear this type of a story?
Yeah, the questions are going to be about, if this person has an infection, why aren't their antibiotics working? Do they have something that's not being covered? Should we do additional testing for other things? And then kind of getting a better history, and, why isn't it working? What are their exposures? What have they been around? Have they been around other people that have been sick? What does the imaging look like? And kind of, why aren't things getting better? And then if things aren't getting better, then you have to wonder, about making some changes, right? And what kind of things should be covered.
Yeah, and I think also, since we're going to talk about TB as well, it's really important to also ask about like travel history and like, were you born in a different country? Did you live in a different country? And I'll kind of show you some of the data why that's important, but it's really going to be important when you have a patient like this to get travel, living history, where they're from. So you just get a better picture.
Yeah, and I think a lot of it comes from the history, like what exposures they've had. Oh, there's a good thing in the chat. It says, are they immunosuppressed or transplant patients? Yes, exactly. So, these are all good questions. And sometimes these things don't come out until things aren't working, until their antibiotics aren't working, their fevers continue. And then it's, should we get more of a history and more of an exposures and an ID consult? Yeah.
So here's a really nice graph picture of the world and where we are in tuberculosis. And just so everybody knows, if you all want to look at TB data for internationally, WHO has fantastic data. They track it really well. So if you Google WHO TB report, you could get all of this data and charts as well. And I gave the link at the bottom too. As you could see, there's certain areas of the country, there's more tuberculosis that's prevalent, Asian countries, African countries, and some areas in South Africa. But we are also seeing TB in the United States, but this is where a lot of cases are.
Yeah, in Nebraska, I think we have a big population from Nepal.
Yes.
And Nepal is, also very high incidence of tuberculosis. And so in those patients as well. And I feel like I see a lot of patients from there with, we have a center in Omaha that takes in a lot of refugees and things. And It's important to look back and see if they've been tested when they first came and what was their testing results. If they had latent TB, were they treated, and these kind of questions.
Yeah, and I think that's again goes back to travel history,
Oh, yeah.
lived history. So it's so
Mhm.
important.
Oh, a high Sudanese population as well. Yes, that's,
Yes,
yeah.
in Nebraska, exactly. So just a quick background, tuberculosis wise, it's one of the major causes of leading causes of death worldwide. Until COVID-19, of course, then COVID-19 took over. And it's also a big reason for patients with HIV to pass away. So again, it's really important when you have a patient with HIV to get latent TB testing done and think about if they need treatment. And without treatment, you can die about 50% of the time. So it's so important to diagnose and treat.
Yeah, I think, and in those HIV populations, like you said, it's tuberculosis is one of the major causes of death of people with HIV. And currently recommendations, 4 to 6 month course of anti-TB drugs. 85% of people can be cured, and that's really what we're looking for is to, treat these people and hopefully eradicate it. And the regimens of 1 to 6 months are available to treat tuberculosis. And the COVID pandemic continues to have damaging impact on access to TB diagnosis and treatment. When COVID really, when you have these outbreaks, it sets everything back, I think.
Yeah.
Everyone, tuberculosis and efforts towards thinking about tuberculosis and treatment and really all other things really decrease.
They had when I did the similar talk a few years ago prior to pandemic, WHO had like eradication of TB by 2050. But now what I worry is we're kind of back again. So we're going to have more work to do to get to where we need to be. So if you look at it in 2019, peak of tuberculosis was 7.1 million. But in 2020 was only 5.8 million that were like diagnosed. That's not because there's less cases, it's because we're not diagnosing them or looking for them. So unfortunately, we're having more cases happening. And in this case, it says we're back to 2012. That's how much time that we have lost in taking care of patients with TB. And this graph just is a big picture. Again, you could look it up at WHO, but it says TB incidence worldwide, milestone reduction 50% by 2025, but we have achieved about 10%. Number of reduction overall for TB deaths, about 5.9%. So we're making some small headways. It's just a good picture, but you all can look at next slide. And here, this is the strategy WHO and all the United organizations have, milestones to end TB global epidemic. So in 2020, the goal was to reduce by 35%, 2025, 75%. We're in target, but we need to continue to work towards that. And the big principles that they're using worldwide is government stewardship and accountability with monitoring and evaluations. So all the governments are being held accountable. Strong coalition with civil society organizing communities. So lots of, healthcare workers, community workers, everybody working together. Protect and promote human rights, ethics, and equity. And adoption of strategy and targets that you can scale up to help the folks with TB. One of the things that they've done really amazing to scale up in a lot of the developing countries is now they have PCR testing on site.
Mm-hmm.
So they could just take a sputum of a suspected patient and do the PCR test in the clinic. So they could start treatment immediately. So this technology is being spun. A lot of countries are working on giving more of this technology. So you could like test and treat instead of waiting for 4 weeks to culture to come back and the patient is no longer here. So there are some good strategies being employed. And this graph, Dr. Horn, is just to see if you look at 2020, prior to 2020, you all see the dip, right? we were doing well.
Yeah.
Unfortunately, now it's going in the wrong direction. I am still very hopeful because now we're doing so much better in COVID-19, but that's where we are headed in the wrong direction, unfortunately. And this graph again kind of shows the top 10 countries that account for more than 90% of a global reduction in cases notification. So the first graph is 2020 to 2019, and then the other graph is reduction in 2021 to compare to 2019. There's still initially before 2019, we had a lot of good reduction in a lot of countries. That slowed a little bit, but they're still progressing. So it's, I still think is positive. It's slowed down a little bit, but they're still continuing to do better. So we just have to make sure right now we work harder to overcome that COVID-19 pandemic effect. And this graph kind of really shows, which is kind of nice, that global trend and estimate number of death caused by TB and HIV. So, it's kind of slowing down. So TB death in HIV negative patients are kind of steady. TB death and HIV deaths have come down nicely, but TB death in HIV positive patients have come down dramatically. And that's because everybody's effort to check for patients with HIV, for tuberculosis, especially for latent TB, and get treated so they don't get infection. One statistic that was pretty scary for me to learn is that if I have latent TB and as a immunocompetent person, my chances of that latent TB become active is 1% a year. But if you have HIV, the chances of latent TB becoming active is 10% a year. So it's drastically elevated. That's why it's really important to check for latent TB in immunosuppressed patients.
So this is a really good graph. So it sounds like it's the combination of getting HIV positive people on treatment and then also checking people with HIV for TB and with TB for HIV and making sure they get good treatment. Yeah, this is really
it's pretty impressive, right? Yeah. If you look in the last 10 years, it looks I'm feeling very hopeful.
Right. Yeah, it's the probably better HIV medications combined with increased awareness and trying to get people treated, right? Oh, that's really good. That's a really hopeful graph.
Yeah. And of course, one of the things Dr. Horn and I worry about is like resistant TB.
Multi-drug resistance. Yes.
And you can kind of see the graph.
The 7 countries with the highest burden. Yes. So India, Pakistan, Russia, China, Philippines, Indonesia, and then South Africa. Yeah, these are, it's tough to try and target drug-resistant TB.
Yeah, there are some development and there are some options, but the 7 countries that Dr. Hone just mentioned, the big areas where they're having more and more drug-resistant TB, thankfully, I have not had any drug-resistant TB in the last few years. Have you seen any?
I haven't. I think one of our partners
might have seen it, right?
Might have had some, and and whenever I have a question, I refer to her.
Yes.
So she's really, but there are excellent resources here to call. The Heartland TB.
Yes.
You can call and talk with an expert, and they're very nice.
Yeah. Thank you for bringing that up. I'm not sure if you all know this, but CDC has tuberculosis sites across US, and each region has a tuberculosis expert that you can reach out to. So if you're in the Midwest and Texas, it's the Heartland Texas Center through CDC. It's easy to Google, but that's a really good point because sometimes I struggle and I call these experts and they're amazing. They return your call, email within hours. And they really walk you through how to take care of a patient.
Yeah, and I called and, I was so appreciative. I kept saying, oh, this is, so wonderful that make yourself available to have these calls and everything. And, they said it's really brings them a lot of, joy.
And they're very passionate.
And, and knowing that they're helping people. And, I couldn't stress enough how helpful. And I felt like I was doing everything right. And a lot of it was they're reassuring me,
Yes.
but they're also telling me things that I didn't even think about,
Yes.
because it's what they do,
Yeah.
they're so good at what they do.
So if you all ever get a tuberculosis patient, of course, we are available. Your health department will help. But if you need extra expert, you could look at CDC TB centers and you could call them or email them. They will be very helpful.
Let's see, TB cases and incidence rate in the United States. And so this is good, it's coming down. Yeah, cases per 100,000 people. Yeah, and then, and this is the dip. This is the COVID pandemic dip, and then it increases.
Yeah.
Yeah, okay. So it looks like it's steadily coming down, and then we've kind of backtracked a bit with this increase. Okay.
And one of the reasons we want to do this talk is like, I'm seeing more patients with tuberculosis, and it's active tuberculosis. And we are missing diagnosis. So I think it's important to keep this in mind.
Yeah, so this doesn't keep increasing, right?
Yeah.
We want this to continue to decrease and come back down.
Yes.
And then by origin of birth. Okay, so this is going to be, are they US born people or non-US born people? So are they essentially, is the tuberculosis transmitting here in the United States, or are they coming from?
Yeah. And then you could see incidence. So clearly in the United States, the incidence is higher in our population who are not born in the United States, the blue graph, versus it's lower in people born in the United States. So that's why, like that patient we started talking about, the 25-year-old initially, it's important to ask about where was she born, where did she travel, where did she come from, and to explain that to you, that patient that I saw, she was not born in the United States. So that's, important risk factor to know.
Yeah, and it looked like it came up a little bit in both non-US and US.
Yes.
So there's transmission occurring
more.
Yeah. People aren't having the correct precautions, or not as aggressive maybe. Or some of the resources may have shifted.
Yeah.
TB in the United States 2021. So by the numbers, 7,860 cases, 526 deaths, 1 in 10 people without treatment. Let's see, 1 in 10 people with latent TB infection will develop tuberculosis disease. And we'll talk more about this, like specific, what makes it more likely for it to come out in some people rather than others, because oftentimes people think, without treatment, the risk is the same for everybody. And that's not the case. And we'll talk about that a little bit. And then, so what is tuberculosis? So it's a mycobacterium. It's airborne bacterial infection that usually infects the lungs. So it enters through the lungs, and then people will have their infection in the lungs, or it will disseminate to other places, spread from person to person through the air, most easily in closed spaces over a long period of time. So sometimes people will say, or they'll think the risks are the same, but it depends on the exposure. How close were they? How long were they near that person? Almost always be treated and cured. So that's also important to realize. And there are different types of mycobacterium. So there's Mycobacterium tuberculosis, and then there's non-TB mycobacterium. And non-TB mycobacterium is found all over. It's found in soil and water, and it's in tap water and things. So even if you're in the shower and the air is misting up, we're all breathing it in.
Yeah.
And so it's all we're exposed to this all the time.
Yeah, and it's important to remember is a non-TB mycobacterium, they don't infect people unless you have a reason to, like immunosuppressed. So most of us, it's just a normal thing in the environment. It doesn't affect us.
So tuberculosis, not everyone infected with TB bacteria becomes sick. A lot of people, their immune system can handle it just fine. And those people, if they've been exposed to it, it's called latent tuberculosis infection. They've been exposed and their body really has it under control. And then there's tuberculosis disease. And tuberculosis disease is when their immune system doesn't have it under control, and it's really causing a problem. It's causing infection. And a positive skin test, a PPD, and or a blood interferon. This is a interferon gamma release assay, not used alone to diagnose active TB. So if you think someone has active TB, you know, if they had a skin test that was non-reactive, or they had a quantiferon, an IGRA, interferon gamma release assay, that was negative, you wouldn't say, oh, they don't have tuberculosis, because that wouldn't be the recommended way to check for active TB.
Yeah, and I see a lot of people getting this confused. So that's why it's really important to know, just because your skin test or serum test is negative for TB, interferon, or PPD, does not mean they don't have active TB. Only way to rule out active tuberculosis infection is to get culture. Or you could do a PCR test on a sample, but you cannot rule in or rule out with skin test or blood test. And just make sure you all are aware of that, because people tend to make kind of mistakes in that area.
Yeah, and they're kind of two schools of thought. Well, both of these are relying on your immune system to have a reaction.
Yes.
And the two kind of theories is, one, your immune system is not recognizing it. For whatever reason, your immune system just isn't recognizing tuberculosis. So you're able to have a really bad infection because your immune system isn't targeting it. Or two, your immune system is so overwhelmed with your active disease that it's not reacting to these tests. And so either way, I think the takeaway is not to rely on these for active disease. Yeah.
So what is a latent TB versus active TB? It's really important to know, because people get scared when they hear the word latent TB. Anytime TB, everybody gets scared. But what latent TB means is you have been exposed, and there's some tuberculosis that got into your lungs, but fortunately your immune system was so good, it just walled it off. We call it granulomas. They just they wall off those TB bacteria, and they kind of go into a sleeping dormant mode. So they're sleeping and they're not active. So if anybody has latent TB, when you do a skin test or blood test, they're not infectious. But active TBs, you just have TB overwhelmingly everywhere. And, you see it in the sputum, everywhere else. So what is latent TB versus pulmonary TB? Latent TB is positive for those serum tests, and their chest imaging will be normal. So there's nothing on their chest. But if pulmonary disease, you can have the serum test positive, but when you do the chest imaging, a CT scan, it's not normal. You have a lot of infiltrates, lymph nodes, cavitary lesion is like a little buzzword, cavity. They form these cavities. And if you hear cavitary lesion in the lungs, you should think about one of the reasons is tuberculosis.
So with latent TB infection, no symptoms or physical findings suggestive of TB, because their immune system has it under control. If done, respiratory specimens are smear and culture negative. So if you're wondering, does this person have latent or active TB? You might say, well, they're at risk for pulmonary active TB. If you do specimens and smears, they'll be negative, and you can say, oh, it's negative. Their imaging looks okay. It doesn't look like they have an active infection at this time. But if you're not sure, you can still put them into isolation and do these sputum smears and check. That's still a good idea. And we'll talk about isolation a little bit more later. But that's latent TB versus active TB. And the symptoms may include, they could have fever, cough, night sweats, weight loss, fatigue, hemoptysis. So they're coughing up blood, decreased appetite. So these people have symptoms and they're sick, and they're kind of wasting away a lot of the time from active TB. Respiratory specimens are usually culture positive, and they can be smear positive also in 50% of the patients. So smear positive is when you collect a sputum sample, when they stain it, immediately they'll stain it and look at it under the microscope and say if they see it, if they see Mycobacterium TB there, and if they see tuberculosis there, that's smear positive. And we usually do 3 smears because it's not a great test. So it can be negative if they don't give you a very good sample, but that's the best way to check if they have active TB.
Yeah, so if let's say you do 3 smears and all 3 are positive, that means they're contagious. But
Yep.
sometimes you could have active TB, but the smear will be negative.
Mhm.
That means you still have active TB, but they're not contagious because they're not coughing up stuff to spread it to others. So it's just some little nuances to know in that area too. So targeted TB testing, right? Essential TB proven and control strategy. Treat person with latent TB who would benefit from treatment. De-emphasize testing of group that are not at high risk for TB and can help reduce waste of resources and prevent inappropriate treatment. So like not everybody needs to be tested for latent TB. So, it used to be in hospital setting, you needed to have PPDs or blood test every year. Now CDC has a risk factor, and in your community, if you don't have too much TB, you could just do a question in your hospital questionnaire versus actually doing PPD or blood test. So that like de-emphasizes and like shifts the resources somewhere else. And then test in high risk population, like, immigrant population, HIV population, immunosuppressed. So that, homeless patients who are in a prison system. So, you just shift your strategy to the high risk population.
And so this is latent TB versus tuberculosis disease.
It kind of like what we just talked about, but puts it really nicely in a table format. For latent TB, you treat, skin test is usually positive, everything else is negative, but in active TB.
Oh yeah, and active TB, you want to be really worried about spreading it. One of the main things is, should this person be in isolation, because that's going to affect other people in the hospital.
Yes.
And that's the main thing, where it's like, when they come in, should I put them in isolation or not? And generally, if there's any concern for it, it's better to put them in isolation and take them out later.
Yeah. So just so, in latent TB, mostly everything will be normal, except for the skin or serum test that you want to treat towards. In active TB, you'll have chest imaging abnormal, your patient will feel sick, they have symptoms, they need treatment, they need isolation. So that's an actual case. And this is pretty much saying the same thing in a different way. How in active TB, like that picture out there,
Yeah.
like when somebody's coughing, just like COVID-19, so much respiratory particles that the other person will inhale and at high risk. So again, big reasons to make sure if you're sick, stay home and get tested, and then also masking in the hospital setting.
Oh, and so factors that predict transmission. So, this is what we were saying earlier about, people will say, oh, I was coughed on, I must have TB now. And, if you were coughed on by someone that has active TB, you may or may not get it. So what are the things that would predict how transmissible it would be from one person to another? So susceptibility. So do you have a good immune system, or do you have immunosuppressed immune system from any of these things? HIV, organ transplant, diabetes. A patient who expels many tuberculosis particles versus a small number. So this is what Dr. V was saying about, they could be expelling a lot, or they could be not infectious if their sputum, if it isn't coming out in their sputum very much. What was the exposure? Were they just coughed on once, or were they in the same room for many hours? And then clinical factors, are they having symptoms of active disease? And then what was the site? So the most infectious, like pulmonary TB, or if they have non-pulmonary TB, they could have TB somewhere else.
Yeah, and I have seen some of the extra pulmonary TB. So pulmonary TB is when you're coughing and expelling, right? But I have had patient with a breast in the breast. I've had a patient with TB in the kidneys. I've had a patient with TB in the liver area. I've had a patient with TB in the spinal area. So you could have tuberculosis in different areas. Thankfully, they're not as infectious because it's contained, right? They're not coughing. So if it's in the kidneys, it's contained in the kidney, urine. So it's not as transmissible. So, but lungs are the most transmissible when you have tuberculosis.
And then characteristics of a patient with TB disease that are associated with infectiousness. So if they're coughing a lot, respiratory tract disease, if they have underlying respiratory issues, or if they have tuberculosis in the respiratory tract, failure to cover the mouth or wear a mask, inappropriate or inadequate treatment. So they're not on the correct antibiotics that would be recommended for treatment. Or if they have procedures like they're coughing a lot or aerosol generating. So like you said, breast TB, I think, if they're going to do something that would isolate it or put it out,
Yeah.
if they're, I think, what is it, spraying it or,
Yeah. So
um,
I've had cases where they'll figure out, oh my God, the patient had TB, right? And then I go back and dive into the case and the OR, the biggest question I always what was the docs wearing? Were they wearing N95? Or were they were spray, there's aerosolizing procedures like bronchoscopy, sputum induction, when you do surgeries, I think cauterizing versus yeah, I'm not the surgeon.
yeah, where they kind of spray it down and it kind
Yeah.
of spray it up in the air.
Yeah, so different on the technique, it puts you at high risk.
Yeah.
Yes.
Yeah, I was trying to think of it too.
Yeah,
I
I
can't
can't think of it, yes.
identifying risk factors that lead to the development of disease. So people at risk for developing tuberculosis disease fall into two categories. Those who have an increased likelihood of exposure to people with tuberculosis, and those who have clinical conditions that increase the risk of progressing. So who they were around, like what their exposure was, and then how immunosuppressed are
Yeah,
they?
the exposure one, and just to touch base, if somebody in the household has it, then the other household members are high risk. If you have a child less than 5 years of age in that house, they're really high risk for developing active TB immediately. Children have low threshold to develop infection tuberculosis. So if you have a child in a house with the active TB case, they need to be tested and seen by a pediatrician and pediatric ID because they're high risk for developing active TB.
Yeah, and these latent categories don't really apply to children.
Yeah.
If a child has a positive test, they just get treated, right?
Yeah, they're especially if they have risk factors and exposures.
Yeah, they don't, and kids don't really have pulmonary TB as much. It disseminates more frequently in children. It can go to their spine and they can get
lymph
osteomyelitis.
nodes, the neck, even like meningitis to tuberculosis meningitis. So it's really important if you have children in mind with the case to make sure they go to the right physician, infectious disease provider, or like a pediatrician.
And I always think of being really aggressive with children and making sure they get really treated. And
yes,
and I usually think of children and pregnant women.
Yes.
And a pregnant woman would be in the immunosuppressed category for high risk tuberculosis.
Increased likelihood, again, close contact, living residents of employees of high risk congregate setting, like a correctional facility, homeless shelter, and also healthcare facilities. And of course, recent immigrant from a TB endemic area within 5 years of arrival is even higher risk. So thinking about that.
Increased risk of progression. And this is HIV infected people, those with a history of prior untreated tuberculosis, and children.
Children, yeah.
And then this is part two would be underweight or malnourished people, substance abusers such as smoking, alcohol, injection drug use, those who have TNF alpha antagonists. So these are people that are on immunosuppressants to treat conditions like rheumatoid arthritis or Crohn's. And I really like this chart. This is a chart that looks at the high risk group. So sometimes people will say, like I've had healthy patients that are young and that when they start working in the hospital, they'll have a test. And if it's positive, they'll come to me and they'll say, oh, the risk of it coming out in me is like 1 in 10, or is it a certain percentage? And really it's a spectrum. And so it goes from the risk of it coming out in a healthy person with no comorbidities. And then, on the other end of the spectrum, it's like a transplant patient or untreated HIV patient, or a patient getting chemotherapy, but a healthy person. But if they have diabetes, it's a little bit more likely to come out. If they smoke cigarettes, it's a little bit more likely to come out. But you never know what's going to happen to them in the future. So you don't know in the future, are they going to get immunosuppressed in the future, or if they have latent TB, we don't want it coming out when they're 80 years old in a nursing home and then causing a health population health issue.
So this just really shows that if you're high risk category, more reasons to get treated for
Yes,
latent
exactly.
TB.
Yeah.
Exactly.
And so, with latent tuberculosis, in general, I like treating all of those people. So they never have to worry about it in the future. They, and people that have latent TB, they'll say, well, what if I become immunosuppressed, like if I'm on something for rheumatoid arthritis, or if I get Crohn's disease in the future, then I'll remember to get tested. But I would feel like just getting them treated and then not worrying about it in the future.
So what are the treatments that we use? So you have a 35-year-old male, just another question, TB, latent TB. He would like to be treated. He, however, lets you know that in the past he started INH and could not tolerate the medication. So do we have other options, right? Because when we think about latent TB, we immediately go to isoniazid INH, but there's other options. So I kind of wanted to show that. So some of the options are you could do INH with the rifampicin, which is rifampin's family of drugs, once a week for 12 weeks. So that's pretty awesome. But this patient might not be the best thing because he doesn't like INH, right? Another option is you could do rifampin alone once a day for 4 months. So you have an alternative option that does not need to be INH. And currently, actually, CDC actually prefers rifampin over INH because rifampin is only for 4 months versus INH alone can be for 6 to 9 months. So I just really think know your options and then see what works for your patient or not. There's another option, isoniazid with rifampin for 3 months, but it's daily. A lot of my healthy healthcare workers, they like to just do that once a week and be done in 12 weeks. Some of my patients, they just like, I just want rifampin and I'm done in 4 months. So just really look at drug-drug interaction, what works for each patient, what modality they would like, but then you have options to choose from. It's important to know that. And those data can be found in CDC. And here's just another question. You have a 56-year-old immigrant coming to the ICU. And they're worried about pneumonia, but he also has lung lesions, and you want to make sure he doesn't also have TB, right? When everybody comes in, we put everybody on vancomycin levo, right, for pneumonia. In this case, what option would you not choose, Dr. Horn?
Well, so levofloxacin has some activity against tuberculosis.
Yes.
And so if you're giving vancomycin levofloxacin, then you're giving them essentially a one drug treatment for tuberculosis. And you never want to give a one drug treatment. So you'd think, what are my options? What could I give besides levofloxacin? If there's something I can give.
Yeah, so just the takeaway for you all is that if you're worried about a patient having active tuberculosis, make sure you're not giving levofloxacin, because then it has activity against TB and you'll create resistance. There's some data I was shocked to see, even if you give like 3 to 5 days of levo, it can induce resistance in TB.
So not levofloxacin, not moxifloxacin.
Yes,
yeah,
you want hydrochloroquine alone.
Yeah. And then active treatment regimens. So this is RIPE. This is rifampin, isoniazid, ethambutol, and pyrazinamide. This is so you start with RIPE therapy for 2 months, and then you can drop the ethambutol if it's pan susceptible, so it's susceptible to everything, and then drop the pyrazinamide at 2 months, and then isoniazid and rifampin for 4 more months. So a total of 6 months treatment for pulmonary TB, and 9 months is considered for more or complicated treatment cases.
And that would include, like, if you have cavitary TB, people who didn't have initially pyrazinamide part of their regimen because they couldn't tolerate it, or if you're HIV with like low CD4 count or antivirals. So those patients not receiving, antiviral, you will do longer treatment. So there are some patients you have to be mindful, it's not 6 months, it's 9 months. And, recently, if you look at CDC for TB tuberculosis regimen, they have an alternative option where it's a 4-month regimen. So instead of 6 months, but instead of ethambutol, they have substituted that with moxifloxacin. So they do high dose rifampicin, moxifloxacin, isoniazid, and pyrazinamide, and it's for 4 months. So again, this is an alternative option if you need it, if they cannot tolerate RIPE regimen. And this website is really good to kind of see what's happening globally for TB innovation. There's a lot of fun money being given, $2 billion in dollars, every year for funding for TB. And also there's a lot of drugs in the pipeline. So they're working on newer drugs. So hopefully something better comes along. So when to isolate a patient is really important. So patient has known TB, positive TB interferon, chest x-ray, cavitary lesion, positive AFB smears, if you have, and symptoms. If you have any of those things, then the patient should be in isolation. Slide, please. When to isolate: symptomatic, order chest x-ray, rule out TB, order 3 AFBs like we talked about. They can be done every 8 hours. Sometimes people think you cannot get it and they wait every 24 hours to get a sputum. We do it every 8 hours to get patient out of isolation. And meanwhile, if you have any questions, ask one of the team members, like especially a physician, IP, respiratory therapist, but put them in airborne negative pressure isolation until you have these results back.
Yeah, and 3 AFB, so every 8 hours and 1 in the morning.
Yeah.
And so some places would have it every morning for 3 mornings, but you could do it every 8 hours. You could get them out faster.
Yeah. And it's really important if you're worried about tuberculosis, the healthcare worker should wear an N95. Patient does not need to wear N95 because it's not fit tested, but patient needs to wear a regular mask to keep their secretions covered. But we need to wear N95 to protect ourselves.
And if you know this patient's coming into the hospital or coming into the clinic, you can alert the staff and tell them put a mask on that patient immediately.
Yes.
once they arrive. Yeah.
So when are they no longer contagious? 2 weeks or longer of adequate therapy, improvement in symptoms, and so it's everything is and 3 consecutive sputum smears is negative. Minimum 2 weeks of treatment, they're getting better, and you got 3 sputums and all 3 are negative, smear negative, then you could take them out of isolation.
And the community health nurses
Yes.
will help with this, and they'll go to the patient's house, and if they have active pulmonary disease, they'll do
they will watch you take it, directly observe therapy.
Yeah, directly observe therapy.
Yeah.
And they'll also do these sputum smears.
Yes.
And so you can follow those smears and watch it become negative.
And special consideration in the hospitals, aerosolized producing requires airborne precaution and N95 and PAPR use. So if you have a patient with a pulmonary TB or extrapulmonary TB, if you're doing any of this stuff, make sure they're in a negative pressure room. But in the OR, everybody need to wear N95 to protect themselves, or a PAPR, because ORs are not negative pressure because they're positive pressure. You don't want to get negative pressure things into the patient's like surgical site. But everybody in the OR room needs to wear a proper N95 or PAPR. It's very important. Otherwise, you could expose the healthcare workers.
All right, and that's everything.
Yeah.
If you have any questions, please ask us any questions you have, or email us any questions you have. But when to isolate, I think is really good. And when in doubt, just isolate them, and then you can kind of sort it out later, because a lot of the time, if they don't get in isolation, then patients may have been exposed. And then
personally, there was a case long time ago where we had to do contact tracing on 100 healthcare workers.
Oh, wow.
So it's really important, like when in doubt, do isolation, so you don't have all these extra work later and exposure. And
those patients that were exposed, did you do
healthcare workers?
The healthcare workers, did you do a quantiferin then and then recheck it again several months later?
They do a 2-step process to make sure that you don't convert. So we did do that 2-step process.
Oh, okay.
Yeah. Well,
Yeah, because that's sometimes a question of when should I get tested?
yeah.
And you can get tested now and then check again in a few months.
Yeah, because you want to know, do you convert? So even if the first one is negative, did you convert later? So you do a two-step process. But it's really important, that's, I think, main takeaways are latent TB treat, active TB treat, isolate, protect others.
Yeah.
And there's lots of resources, and then when you see a patient, get background information, travel information. And if you see cavitary lesions, high suspicion, so that you prevent less exposure to others.
All right. Not
Thank
seeing
you
any
all.
questions. Thank you, everybody, for joining us, and please
Happy holidays.
happy holidays.
See you in January, and we'll send out different topics soon. Thank you.
All right. Bye, everybody.